There are three main reasons for taking a dermoscopic image. First of all, simply to put in the patient's records so that you have an image you can compare any change at a later date. Secondly, I think most of us are taking images now which we want to send to a dermatology department for a second opinion and some advice on how to manage that particular lesion. And then finally, you may want to take some images with a very high quality camera that you may then want to use for giving presentations or for collecting a dermoscopic library. I don't think you need consent for just taking an image to put on the patient's records, any more than a radiology department has consent for taking an X-ray. But if you're taking an image that you're sending out of the building on the internet to another department, I think it is good practice to include consent for email advice. If you're taking images for the purpose of education and presenting to doctors and perhaps even putting on the internet for other patients to see, you need explicit consent. When you're sending an image for a second opinion or some advice on managing it, good information going with that image will make sure you get a really good opinion back. So be sure to attach not only the patient's initials, I don't give the whole name, also their date of birth, that's really important, but also their NHS number. The NHS number should ideally be in the subject line of your email. I then think you should make some kind of assessment of what sort of risk. Most of the time we're looking, is this a skin cancer or not when you're doing dermoscopy? So you want to first of all make an assessment, is this patient at risk of having a skin cancer? So the sort of information that make it very useful for the dermatologist who's looking at the image will be, has there been any past or family history of skin cancer already? And has the patient noticed any change in the lesion? What is it that's worried the patient? What's their skin type? Do they tend to burn when they go out in the sun, or do they tan easily? Where have they lived? Have they lived usually in the UK, or have they lived abroad? Do they have their holidays abroad? And what's their occupation and what are their hobbies? Do they, for example, play the piano and sing and do things indoors, or are they outdoors playing football, walking around and getting plenty of sun on them? Have they had any episodes of severe sunburn in the past? And in particular, have they ever used a sunbed? Apparently, one use of a sunbed under the age of 35 in somebody with type 1 or type 2 skin colouring increases their lifetime risk of melanoma by 75%. And every subsequent use of a sunbed increases it by a further 25%. So sunbed use is important. And finally, I like to know whether there's been any history of immune suppression. It's particularly important with patients who are severely immunosuppressed, for example, with a renal transplant or equivalent, but also patients who are on long-term disease-modifying drugs or steroids by mouth. They too might be at increased risk of skin cancer. So I think that information should be included with the images. Sometimes you only want to take the image of one lesion and you only want the opinion on that one lesion. But there are occasions when the patient may have an unusual looking mole, which actually is perfectly innocent because it fits in with their signature pattern. So in that situation, I think it would be really helpful for the person seeing that image if they could have several of the moles photographed and clearly identified. This is a mole from the center of their back, this is below their right scapula, this one's on the middle of their tummy, or whatever, the middle of the front of the abdo. So the doctor looking at the image can say, yes, it does look a bit odd, but it's clearly within the signature pattern for that patient's moles where they have reached. And so therefore I'm happy that that is okay. If they just saw that one mole, they might say, I'm not sure, perhaps we'd better get it out. But when you have a lot of moles that look similar into the same signature pattern, if you can give that information with the email, for the email advice, for the doctor looking at the images, that may save the patient an unnecessary excision. Another point is that if you've got a particularly bleeding or crusty lesion, dermoscopy isn't usually very useful. So it's not desperately useful thing for looking at squamous cell carcinoma, for example. There are features that we can look for, but usually if you've got a crusty or scaly lesion, dermatoscopy is unlikely to give you that much more information. The next thing is, I think, make your own assessment of the lesion clinically, examine it and look at it. And so you want to know its site, its size. If you're thinking perhaps it could be a squamous cell carcinoma, you'd probably want to squeeze it to see if there's any induration. If you think it might be a basal cell carcinoma, a particularly superficial one, you might want to stretch it to see if you can create that so-called whipcord edge, the sharply defined pencil line around the outside where it's just a little bit raised. And then finally, I suggest that you try to describe the lesion and include with your letter your own assessment of what it could be. So I think this might be such and such, or I think it's probably an inflamed seborrheic keratosis, but I'd value your opinion because they've noticed some change or whatever. It's worth taking some naked eye images first of all, so you can orientate where the lesion is. So for example, it's on the limb, you might take a photograph of the entire limb, and then a close-up image of the actual lesion that you're concerned about, so that we can see exactly what it looks like. And then you come down to doing the dermoscopic image. So when you come to take the dermoscopic image, obviously the easiest is with contact. So you have a gel contact between you and the patient, and your dermatoscope is now in contact with the patient. So if they move, you move, and it stays properly in focus. You can take images through the polarizing mode, and that gives a slightly different depth of image. You don't then use the interface gel, and it can be useful for picking up different features on dermatoscopies, for example, white structures in the dermis. But I generally speaking am using contact dermatoscopy with a gel interface. The gel I use on the body is the alcohol gel. That's the same sort of thing that you use when you wash your hands or clean your hands between patients. But obviously if you're doing anything close to the eye in this sort of vicinity, I wouldn't want to get any spirit into the patient's eye or alcohol. And so there I use either KY jelly or simple ultrasound jelly. So you get your dermatoscope. I usually put a generous blob of the gel on the actual lens, so I can then fold that onto the skin carefully to try to ensure I don't get any bubbles. Now clearly with a large papular or nodular lesion, bubbles are going to develop around the edge, and that can sometimes be impossible to avoid. But by having a generous blob of gel on the lens, you can usually avoid that. Always have your light turned on to absolute full light, and then just get it in focus and get the image that you want to look at to decide what you're going to take the photograph of. When you come to take the photograph, you can use your camera just to open the image out on your touch screen so that it fills the screen as much as possible. What you don't want to do is send an image with the ring of the dermatoscope showing. So you want to open it up so it fills as much of the screen as you can. If the lesion is more than about 8 or 9 millimeters, you won't get the entire lesion on one image. So sometimes I take it in 4 quadrants so that I can get the whole lesion that way. Otherwise, if you can get the whole lesion in and you can open it up, that's perfect. If it's got a long axis, orientate your camera so that the long axis of the screen is in line with the long axis of the lesion. And I like to try and tidy it up so that the graticules, I know with the Opticlar you have 2 lines, you have the X and Y axes. If you're using a Heine Delta, you just have the one axis. Line those up neatly along the edges of your screen, and ideally just slightly away from the lesion, so the lesion is undisturbed by the graticules. But if that's not possible, it doesn't matter if the graticules go through the lesion. It's important to avoid too much pressure on the actual lesion itself, because then you'll just squeeze out the blood vessels. Blood vessels are really important for the purpose of making a diagnosis. For example, you can have dotted and chopped up vessels and linear irregular in melanoma. We obviously look for the micro-branching and macro-branching telangiectasia, which are sharply in focus in a basal cell carcinoma, perhaps comma vessels in a benign dermal nevus, or hairpin vessels in a seborrheic keratosis, or the string of pearls, for example, in the clear cell acanthoma. And then we've got glomerular vessels in Bowen's disease. So those are the classic sorts of vessel patterns we might see. If you press too hard on the lesion, you'll just squeeze the vessels out and you'll lose all that detail. So just have enough pressure to have contact, to slip off the bubbles, and not too much to squeeze out the vessels. So you take your phone and you snap it into the sleeve like this, taking care at the time not to turn the phone off or open any programs. Then you take your dermatoscope and the split O-ring, slip it over if it isn't already in place, and then close the wheel down like that so it's nicely in focus. You have the sleeve component here, and you just screw these together here, like this, nice and tight. They come separately. And then you add the magnetic ring, that just screws on like that. I like to connect these two together in this sort of position so that I can move the camera around in that sort of position, so I can move the camera around, holding it fully, tightly, the focus ring tightly pushed down to onto the dermatoscope. So that's the sort of position I use. I don't put it on here and then take it out of focus. I like to keep it down there nice and tight for me. And then you turn the dermatoscope on, you put some gel on, you attach this here, you bring it round to about there, and then I like to have my hand in contact with the patient, so if they happen to move, I move nicely with them. So I then bring this here, put this onto the patient, onto the lesion, and then I move this round until I've got the graticules roughly in line with this nice long axis and across the top if you're using the Opticlar. But with the Heine, you just got the long axis this way. Open it out this way, like that. Get it nicely lined up. Open it out a bit more. Get it to the point at which it's showing the lesion that you want to show, and then in that position you just take the photograph. If it's not in focus, you can actually touch the screen, but it does change the white light and makes it a little bit darker. So the image might be better in focus. I take 2 or 3 photographs so I can choose the one I think is the best in focus and looks the best. So that's taking it with the Heine Delta range. The Opticlar range, this is the dermatoscope most of you will have. Here you need to take things apart again, and you need to take this little magnetic ring off here, and rather than being given the sleeve connector for the Heine, you now have the sleeve connectors for the Opticlar, which you would have been sent. So again, you just connect those two together like that, screw that on nice and tight. Same with this, the magnetic ring on the outside. Nice and tight. Connect that on, and you're away. Turn the dermatoscope on. That fixes onto here. You need to have the ring in here. So again, you would have had a split ring which slides over that. That tightens down like that. That goes on there like that. Swing it round, and then in exactly the same way, you open the image out. When you're happy you've got the image you want, you can tap on it if you wanted to get better focus, and then you just take the photograph. And you now have that photograph on your phone. With the DermLite 3, the first thing to do is just unscrew the eyepiece and put that aside. Then onto the same threads, you get the magnetic ring, and with the magnetic face out, you screw that onto the DermLite. Make sure it's done up nice and tight. At this point, you can always adjust the focus a little on the DermLite. And then once it's turned on, you can then click it into place with the sleeve. So your iPhone is now attached. And then in the same way, with contact with the patient, you can actually increase the image size so that it fills the screen. When you're finished, it just separates as easily as that, and there it is. So taking a photograph here, turn it on and add a nice generous blob of the interface gel. And you make the image a bit larger, and now I want to try and get the graticules so they're neatly along the bottom of the image. Try and get it nicely into the center. There we go. That's looking good. Now I want to get it nicely focused. So let's get it properly centered. Still got the graticules just at the bottom. Graticules straight along one line, preferably just off the lesion. The image is now ready to be used. And this is how you put together the digital camera package for the dermatoscope. So you've got your dermatoscope, the ring, the O-ring, the split ring, your digital camera, the sleeve and the connector. First of all, put your split ring on there, slip it on properly and push that down like that. This will come with the screw attached here. You just simply unscrew that. It's just there for storage. Put that down like that. You then take your camera and you turn it on. And you take the bracket and lay the aperture over the lens like that, and the plate at the back should just fall neatly over the screw hole. Then with the same screw you just removed, you attach it to the camera and do that up nice and tight. If you turn the camera over, you can just make sure that the aperture of the bracket is nicely centered on the lens. You can adjust it in both planes, forward and back, so that it's in just the right position there, tightly up against the camera and in the middle. Make sure all your screws are nice and tight, and then you take the little cup that has come with this bracket and that just neatly screws onto the front like this. Again, make sure that's done up nice and tight and that you don't dislodge the position. Then you can fit the two devices together. It just slots onto the dermatoscope like this, and away you go. You can expand the image as necessary. Now, taking a photograph with the Heine Delta dermatoscope and the camera, turn it on and add a nice generous blob of the interface gel, because this is the non-polarizing plate. Attach the camera and twist it clockwise so that the ring is nice and tightly down onto the dermatoscope, and then look at the image through the camera to see that you're in the right place. Now, the first thing to do is to expand the image so that it fills the screen as much as possible. So you need to expand it a bit further with that little lever on the right hand side at the top of the camera. Bring it up like this, and then orientate the camera if you can, always moving it clockwise so that it stays in focus, so those graticules are nice and neatly along the bottom of the image. Make sure it's nicely centered as well. Often I take a photograph at that point just to have one already. It's a bit fiddly, isn't it? And then just make sure you're nice and centered here. And then if you partially depress the image capture button, it automatically focuses, and then a deep depress takes the image. The image is now on the camera and ready to be used. Here are a couple of useful accessories for the Opticlar. First of all, you can remove the lens cover here, just slip it off by just moving it to there, put it there. And this is what I call the nipple attachment, really useful for getting into rather inaccessible areas, like for example behind the ear, between the fingers, and also, for example, by the side of the nose, so near the eye. So the difficult areas where you can't get the full lens pushing against the lesion. Of course, with this you only have the non-polarizing contact resource, and then you just put a little blob of gel on the tip there, and then away you go, and you can get into that nice difficult area with this device that way. A really nice feature of the Opticlar is this disposable lens cover. So just in the same way, you just can remove that. And we have this lens cover which has a gap there, but the lens at the base. And that can fit on here just in the same way. And then the disposable lens cover, your Opticlar would have come with about 10 of these in the box, then just clicks on like that. And that's really good for looking into difficult areas where you don't want to have contaminate your dermatoscope, for example, the genitals, or you've got a particularly nasty weeping lesion or a crusty lesion that you'd rather not have contact with. It can have both the polarizing mode and the non-polarizing modes as the normal lens. The other really useful feature of this is that if you take this lens, this disposable lens cover off, you now have a gap there in front of the lens here. You can see if I put a finger into there, lens cover itself is actually down towards the base of this. And now if you want to look at a vascular lesion or a very soft wobbly lesion, you can actually put this onto the skin, have contact with the lesion in the center of that hole, and you're not putting any pressure on it, so you're not going to squeeze out the blood vessels. So that's a really clever additional resource for the Opticlar. I just put it back together as it normally is. There we are. It will give you the option when you're doing that to select the number of megabytes or kilobytes you want to send. I find with the iPhone 5, most of the images I take are around about the 600 to 800 kilobyte size. Emailing anything up to 1 or 2 megabytes is not a problem. Beyond that, I think you're creating problems all around. So I might reduce its size a little, particularly if I'm planning to send a few photographs. I personally send them individually and then pick them up on my email, on my desktop. And then what I do is I save them onto a file on my desktop of the computer. Don't forget to delete them from your camera. You shouldn't leave these photographs there. And I think you may just be aware that a lot of cameras will have this facility for uploading. As soon as they're in contact with the internet, they will upload your images to the iCloud. So you shouldn't be keeping these on your phone. So delete them from there. And I then delete the email. Once I've saved the image that I've sent to myself, I then delete that email as well and delete it from my deleted folder on the email. Be sensitive to your local clinical governance rules regarding the sending of identifiable information over the internet. Obviously, it's safe from one server, from one nhs.net address to another. But if you're going like I do from Hotmail to nhs.net, you probably shouldn't be doing that through the internet. Now, in that situation, you should obviously attach the lead that connects it directly to the computer, and then from there, through DCIM, you can upload the photographs directly and then put them into that folder that you've created. Remember to keep all your kit clean and safe. This kit is, these dermatoscopes, as you all know, about £600–700. They're very pilferable, so keep it in a locked room, ideally in a locked drawer. I actually keep mine in the charger at all times, so it's fully charged. I think that's important. So it's in my locked consulting room. But keep the dermatoscope clean it between patients. You've got that alcohol gel, you can just clean the lens, just make sure it all looks nice and clean and professional. I think nothing worse than putting a piece of dirty kit on a patient. They won't appreciate that. It doesn't look professional.
So in order to attach and send a document via EMIS Web, you go to the Attach Document via the top left button, select your document, and press the Open button. You can then check it, make sure that you've edited it to your liking with the tools along the top, and then in the top left box there is a Type button. I chose Clinical Photograph, and the top right you can choose yourself. There's a toggle switch for keeping the original or deleting the original. I've chosen to keep the original in this case. And then in the bottom right, press File to file the document into EMIS Web. Then in order to send it, you double click it to open it again, and a Send button will appear on the bottom bar with a little down arrow that you can choose Send via email. When you click this, it will open up Outlook with a pre-configured email with the attached photograph. You then put your destination email address in and your text of your email and press the Send button, and that's all there is to it.